But it gives me very great pleasure now to introduce Professor Richard Murray to you. Professor Richard Murray is a senior clinician who comes from Townsville, and he has recently joined the task force, and he'll be presenting to us today about it. So please welcome Richard Murray.
Okay, thank you very much for that kind introduction. I'm very pleased to be here. I'd like to acknowledge the traditional owners of this country. I'd like to acknowledge the conference organisers. What a fantastic event, standing room only. I stood at the back. I thought it was fascinating, the last session, so thank you. I'm come into this, I suspect, they didn't really tell me, but I suspect it's because I've had a career in remote health, in community-based organisations, in isolated areas, in Aboriginal communities and so on. So I bring a particular perspective. But what's happening, of course, is this task force, the National Eyes Task Force, and I'm going to give you a little bit of an overview of what's occurring with that. And I'm also going to share some personal perspectives and thoughts as to how we might get the most out of what's now in train. I'm not going to... Look, infographics, I mean, they're great, aren't they? There's nothing you can't do with an infographic. It's like the traffic lights. I mean, you know, everyone's got to have a traffic light system and everyone's got to have an infographic. It's not a bad one. And I think it is handy to try and crystallise for everybody what some of the key facts are. One of the things I'd say is that the motivation for this has been, I think, my impression, quite honestly, is it's quite authentic. So ministers in particular, Fiona Nash, for instance, happily shares the notion that everywhere she goes, it's the thing that people stop to talk to her about. And I guess this is reflected in where we're seeing corroborative evidence for that. So the rise and the substitution, in a sense, of crystalline methamphetamine, highly purified, relatively cheap, broadly available, spreading and grabbing new ground from historical areas of high use into sort of virgin territory, or relatively, is palpable and obvious at the community level, and in some settings really obvious. I had some Aboriginal health workers from remote Kimberley stay with me recently for a funeral in my town, paying respects to a dear friend, and they experienced women speaking about the transformation of their town and how frightened they were by what's occurring. So I guess I'd say, just by way of opening, there's an authentic sense, not of moral panic, but of concern as a result of change, and that is driving this. It's not political opportunism. I think it's quite authentic. So we had a task force. I accepted the invitation to be on the task force. It's chaired by Mr. Ken Lay, who's a very experienced, ethical, upstanding and thoughtful former Commissioner of Police from Victoria. And I hope this is not being recorded, at least I didn't say anything bad. And Sally McCarthy, who's actually been on an ad campaign in the past, a very experienced emergency physician. And the emergency departments are one of the areas in which people have really noticed impact of change of drug. So there's a fairly accelerated timeline occurring. I don't know what timeline is a perfect timeline. I suspect probably 18 months or 2 years people would be asleep by the end of it. You know, if it's 6 months, you know, that's probably even a bit stretching it. I don't mind tight. I think that tight's okay. I think it's more about the competence and the capacity and the seriousness with which it's taken. And I'm happily share my opinion that I think that the team that has been brought together under the umbrella of the Department of Prime Minister and Cabinet is, I think, first class. So there are some seriously smart and talented people with multi-sectoral interests who have been assembled around this and who are, you know, the driving backroom engine, and that gives me confidence. And I think that there is a necessarily not exhaustive, I mean, it's only, what is it now, 7, 8 years since we had 200 and something consultations with the ATS strategy. I mean, you know, we've done a lot of this before, haven't we? So it doesn't all need to be done again just because, but it is important to gather key informant information. So peak groups, AODs, professional bodies, community groups, sample community trying to get a sense of what is going and what's changed, and then couple that with a thoughtful appraisal of the evidence. So I mentioned there's an interim report, and when I say that's really, this is what we have heard, this is what's being said, this is what the literature is telling us, this seems to be the direction to go, and then some work to develop something into a national strategy by the end of the year. Fiona Nash I've mentioned, the other minister is Minister Keenan, similarly at a federal level in relation to justice. I guess the other thing, for those who are not policy wonks and aficionados of how things happen, this is happening under the auspices of COAG, the Council of Australian Governments. And so unlike, say, National Drug Strategy or other things which tend to be industry or sectional interests, this is happening at the sort of peak level. So this, and I'll come to that in a minute, why might that offer some things that might be, what's in that approach that might be of value in terms of that getting traction and real outcomes. Okay, there's a evolving schedule of visits. There's already been consultations begun with professional organisations, with AOD sector and some others, and then there are now moving into a sort of a sampling around the country of a diverse range of settings. And I'll come to the importance of local. I think the trouble with averages, on average there are X%, 1 in 14 Australians have, is that it hides the truth on average. So pockets of high use and problems are hidden amongst the other populations, and what you get is a sort of blancmange answer, which does not come to the truth. And so I think sampling and getting some authentic evidence of what's going on is important. So I'm just going to sort of skip beats slightly and give you one or two perspectives from me about what the sort of things that it's helpful to keep in mind, I guess, as we wrestle with this. And I put that image up, which I pinched off Dr. Google, because to remind myself that this is actually about complex systems. I mean, look, to every complex problem, there is an easy and straightforward answer that is wrong. These are complex problems that require a systems thinking approach because it defies simple linear intervention. You need to be thinking about, this sounds like a good thing to do, let's push that there, and blow me down, something pops out there which we didn't recognise would happen. So driving, use underground, getting in the way of help-seeking behaviour. Some examples I'll talk about in a moment. I'd offer this too as a resource for anyone who likes to think practically about systems thinking. This is in the health sector. This is a WHO and Alliance for Health Policy and Systems Research publication. If you just Google the title, you'll find it. Dr. Google's actually quite good. I think this is the right sort of approach. I mean, for instance, this is simplified, but some of the ways in which you need the street level actors, the people who know how stuff works around here and how we get around these stupid directives that management tells us and what we would do if that happened. I mean, and so those perspectives need to be brought together. There's got to be some thinking. There's no linear hypothetico-deductive sort of process, and it's really and there is an emerging and evolving methodology as to how we might think about complex systems. For instance, this is an analogy used in asbestos research. It's nice snakes, black snake. You say asbestos and people say the black snake, and then all of a sudden you can't work on your house and you can't live in it. It's all just really hard and horrible. And one of the dangers of talking about and isolating crystal methamphetamine in this context, scaring populations and so on, is that there is an issue of mobilising community and political support behind an issue in order to make it possible to apply resources and effort. That's legitimate. But on the other hand, as we heard in the last session, I think the notion of marginalising users who say, that's not me. The notion of privileging one substance over another when we know poly use is a real issue. The questions of undermining the confidence of frontline workers who actually do have skills and who don't need to get a feeling that they're out of their depth. not least because a lot of what we know is useful to do with methamphetamine is useful to do, but not wildly efficacious, and really just sort of going back to first principles of brief interventions and supportive networks and all the rest of it is sort of people should know. Does that mean that doing public campaigns to raise consciousness is wrong? No, just you have to be aware of the consequences, and it can only be part of the story. It can't be an answer. And you can run across anything like this, where services coordination sounds like a good idea. AODs, mental health, what a fabulous thing. Why is it so hard? What is it about professional and sectoral identities bound up around funding and history, that makes it hard at the level of the patient and community, to the user and community, whatever, to just mobilise and wrap services around the person and their family instead of wrap the people around the services. I mean, why does that defy? What are the factors underpinning that? And it's more than just a care protocol, it's more than just a care pathway. And I think that these are useful things to consider. The resource contestability collaboration, we had a nice discussion last week. The notion, it does seem over the last 10 years we have become a lot more conscious of a sort of a care and diligence in financial contracting relationships between government and service providers. And that's actually a choice, because you can do that. The term was, the government becomes your fiscal entity as you go into the period of re-tendering or recommissioning, as opposed to being a partner with policymakers and funders in an evolving story that is stable and is capacity building. There's no perfect answer, but we know there's some problems in there, don't we? Law enforcement, help-seeking behaviours, yes, I think restriction supply works. It's one of the few things it does. If you have to spend half a day getting something as opposed to half an hour, it makes a difference. That's evidence-based policy. But if you drive that too hard, you have consequences in relation to driving people away from help-seeking. So, it's complicated. So I'm going to I think I'm drawing to a close. What I'd really ask people who would wish to inform and provide input into this is please do, and put whatever you like in, and if it's not well formatted and it doesn't have numbers and so on, you won't lose marks. You won't be regarded as a sort of, put it in. And if you need to put the same in twice, or you're only dealing with a narrow issue, we are, particularly with this accelerated time run, looking for data from informants, particularly informants around some of what is it that we could actually do as a nation, backed by a Prime Minister, premiers and sort of, and engaging as to the greatest extent possible with local government. What is it that we could do that would actually contribute something positive? And I guess one of the things we sort of know is that ultimately this has to coalesce around the local. It's the local where people live and choose to use or not use, get their support or don't get the support. And that is contextual. And so how can whatever we might conceive of nationally, a framework, how can that coalesce around the diversity of local, the sprawling western suburbs of Sydney, the remote communities of the Kimberley, the mining towns with FIFOs and DIDOs. I mean, what can we do in this context that draws together the health and the helping services, the law enforcement community leaders, peer educators, ex-users and so on, activists? I mean, what are the tools? What's the resources? What's the enablers? Or can we remove some blockers that we might usefully do? Give me a stand up. Okay, nearly finished. Information technologies, coordination, all the rest of it. I mean, that's a set of things that I think we should really turn our minds to. And you are immersed in this, passionate about it, expert. Please give your advice as to what might be usefully framed by whole of government. And that's where you can contribute. Dr. Google can tell you too. So anyway, thank you. I think I've overused my time. Ta.